A software bug caused critical medical records across an entire hospital to vanish, altering medication doses, erasing allergy warnings, and rendering patient histories utterly blank, directly contributing to the deaths of multiple patients. This wasn't a sudden, dramatic explosion or a physical collapse, but a silent, creeping digital amnesia that paralyzed care and left doctors flying blind. It began subtly, like a whisper in the vast, interconnected network of the hospital. A nurse on the night shift, reviewing a patient's chart, noticed a discrepancy. A critical allergy to penicillin, clearly documented hours earlier, had simply disappeared from the digital record. She double-checked, thinking it was her mistake, perhaps a new system glitch. She manually re-entered it, but then, an hour later, a different patient's recent blood work, flagged as abnormal, was no longer visible to the attending physician. The digital system, designed to be infallible, was beginning to lie. This advanced electronic health records, or EHR, system was the hospital's pride. It promised seamless integration: patient admissions, diagnostics, lab results, pharmacy orders, nursing notes, billing, all centralized, instantly accessible. It was meant to eliminate human error, prevent miscommunication, and ultimately, save lives through efficiency. But in the quiet hours of that night, its very efficiency became its most terrifying weapon. The discrepancies, at first isolated, began to multiply, accelerating like a viral infection within the digital bloodstream of the institution. What started as minor inconveniences quickly escalated into chaos. Doctors couldn't confirm medication dosages. Orders for life-saving drugs were overridden with placeholder values or simply vanished. Critical care patients, dependent on precise, hourly adjustments, were left without clear directives. Surgical schedules, painstakingly planned, disintegrated as patient information needed for pre-op clearances vanished. The hospital was running on instinct and memory, a relic of a pre-digital age, but now without any of the old paper trails to fall back on. Every physician, every nurse, was suddenly forced to improvise, desperately trying to reconstruct vital information from their own fleeting memories or fragmented notes. The source was eventually traced to a seemingly innocuous software update rolled out a week prior. A tiny piece of code, designed to optimize data synchronization between the main patient database and a legacy billing system, contained a critical flaw. Under specific, rare circumstances, perhaps when a patient's record was accessed and simultaneously updated by two different departments within a fraction of a second, the synchronization logic would misfire. Instead of reconciling changes, it would interpret one update as an erasure, and then propagate that erasure across the entire network. Data wasn't just being corrupted, it was being systematically deleted, often replaced with default zeros or null values that signaled an absence of information. Imagine a patient in the intensive care unit, fighting for breath, their life hanging by a thread. Their digital chart is supposed to display real-time vital signs, a continuous stream of data about their heart rate, blood pressure, oxygen saturation, and response to medication. Now, imagine that stream going blank. The monitoring system, receiving corrupted data, would display zeros or simply freeze. Nurses, frantic, would initially suspect a hardware failure, frantically checking connections, only to find the machines were working fine. The problem was deeper, invisible. The patient was still there, but their digital self, their medically critical identity, had been wiped clean from the system. This digital amnesia wasn't selective, it was indiscriminate. Patients with chronic conditions, whose entire treatment history was essential for current care, found their past wiped away. Allergy warnings, painstakingly entered over years, were gone. Medication reconciliation became a terrifying guessing game. How do you prescribe a life-saving drug when you can't verify past reactions or current contraindications? The hospital transformed from a bastion of modern medicine into a high-stakes, real-time crisis zone, where every decision was shadowed by profound uncertainty. The IT department, already stretched thin, was overwhelmed. Initial attempts to restore from backups failed. The bug, insidious and pervasive, had already tainted some of the recent backup files, or the sheer volume of lost data made restoration an agonizingly slow, incomplete process. Every hour that passed without accurate patient data meant increasing risk. Each new shift of nurses and doctors inherited a fresh wave of digital chaos, adding to the cumulative confusion and exhaustion. The human element of care, already strained, was pushed to breaking point. The ripple effect was devastating. Diagnostic delays led to conditions worsening. Medication errors, born from a lack of information, caused adverse reactions. Critical alerts for deteriorating patients were never triggered. For some, the disruption of continuous, precise care proved fatal. Families, already grappling with illness, were plunged into deeper despair as their loved ones received incorrect treatments or suffered preventable complications, all due to an invisible string of faulty code. How do you explain to a grieving family that their loved one's death was hastened not by medical negligence, but by a line of code written thousands of miles away? The investigation that followed was a painstaking forensic exercise, tracing back the lineage of the software, analyzing every commit, every merge request, every update log. The flaw was ultimately identified: a boundary condition error in the data synchronization module. A scenario that should have been gracefully handled by the code had instead become a destructive force, turning valid data into null values. It was a stark reminder that even the most advanced, rigorously tested software can harbor hidden vulnerabilities, triggered by unforeseen combinations of events. The incident served as a chilling testament to the fragile interdependence of modern healthcare systems. We place immense trust in the digital architecture that underpins our lives, often without truly comprehending its hidden complexities or its potential for catastrophic failure. A single, seemingly minor error in a vast ocean of code can propagate outwards, silently undermining the very foundations of care, leaving behind a trail of confusion, despair, and ultimately, unimaginable loss. It forces us to confront the uncomfortable truth: in an increasingly digital world, the invisible lines of code can hold the power of life and death.